Hello there, it's Luke, and in this tutorial, which is our second tutorial on septic shock, we're going to be thinking about the physiological mechanisms which bring about the signs that we might see during late shock, or what we might call late septic shock. And we're going to be thinking about these are some of the signs that you might expect to see in somebody who's in the sort of later stages, a more severe perhaps version of a septic shock. And we're going to be thinking in particular about things like the respiratory distress, and so the ARDS that they may have, the cool peripheries and the very sort of thready, difficult to palpate pulse, and also the rash that you may see that is sort of typical of meningitis, or something called disseminated intravascular coagulation, which we'll talk about in more detail in just a moment. So you'll recall from the previous session that we have this definition of sepsis where we are flagging up that there's a dysregulated host response to infection, and that is brought about both by the invading microbe releasing endotoxins and the inflammatory mediators that are sort of running wild that the body's own cells and liver produce. Now, the sort of focus of this tutorial is really to think about the microvascular circulation. So we've got a failure of perfusion that is in part sort of gross and occurring all around the body, but really a lot of the process, a lot of the issues that we have with sepsis are at that sort of much smaller level, right down at the sort of capillary level. And it's important to realise that you may have septic shock, so you may have that failure of tissue perfusion, and it might all be happening because of changes in the microcirculation, but you may not necessarily, at least to begin with, see a drop in the systemic blood pressure that we would normally assume to sort of equate with shock. And the international definition reflects that. It doesn't talk about there being a drop in blood pressure being diagnostic for shock. So just to refresh our memories, we've got sort of three fluid compartments: the fluid inside the cells, the fluid around the cells, and then the fluid in the blood vessels. And respiratory gases, so oxygen and carbon dioxide and nutrients and waste products, move between those three compartments. So we want to get glucose and oxygen into the cells, and we want to get rid of the waste and the carbon dioxide out of the cells so they can be dealt with and excreted. And this is what we're talking about when we're talking about perfusion. So in order for this microvascular circulation, this all the blood flowing through the capillaries and exchanging respiratory gases and toxins and nutrients with the tissues, we need to have four things. We need to have a reasonable arterial blood pressure. We need control of the arterial tone to sort of let in just the right amount of blood through the capillaries. That blood needs to be able to flow easily through the capillaries, and the capillaries need to be patent, so then there can't be anything blocking them. And here's a diagram to represent that. So if we look at this, when we talk about our microvascular circulation, we're really talking about the sort of capillary networks through the tissues. Is our BP high enough? Are the arterioles, are they able to control the flow of blood and nutrients and oxygen through the capillaries within the tissues? And is anything obstructing that flow? Is anything blocking those capillaries? So first of all, we'll think about arterial blood pressure. Now, thinking back to the previous session, we've already mentioned about vasodilatation due to inflammatory mediators like interleukins and bradykinin and that kind of thing, and that will affect our arterial blood pressure. But on top of this, we're going to think about tissue fluid. So here's our capillary again, surrounded by the interstitial space. And recall the Starling's forces are at play here, and there's a movement between fluid initially out of the blood vessel due to the hydrostatic pressure from the arterial blood pressure, and then fluid is drawn back in to the capillary vessels because of the oncotic pressure from the proteins and the other sort of bigger molecules within the blood vessel. Well, during a sort of big inflammatory response, inflammatory mediators such as histamine, bradykinin, tissue necrosis factor make the capillaries more porous. Okay, so the endothelial cells actually sort of contract, and so consequently you get more fluid. The hydrostatic pressure has more influence because there's bigger holes for the fluid to flow through out of the vessels and into the interstitium. Now, part of our inflammatory response, part of our immune response, is to get the blood cells and the proteins and the nutrients from the bloodstream and into the tissues where they can begin to fight the microbes and sort of repair the damage. But these white blood cells and proteins and all these other things are osmotically active and have sort of an oncotic pull on the fluid away from the blood vessels and into the tissue as well. So we've got these two things occurring at the same time. There's more fluid coming out because the holes are bigger, but also there's a pull from the proteins and the white blood cells and all the rest of it that's leaked into the tissues, keeping the fluid within the tissue, and it can't go back into the blood vessel. And so we get more edema, but we also get less venous return back to the heart, and in doing so we get less preload. And both of these two things combined, so the vasodilatation brought about by the inflammatory mediators and the leak of fluid from the capillaries, meaning that fluid is sort of leaving the circulation, forming edema, and the fluid is not being returned to the circulation, and so our heart isn't pumping as effectively because it's not being stretched by the preload, meaning we have a drop in our stroke volume, a drop in our systemic vascular resistance, a drop in our blood pressure, and also this will affect tissue perfusion. And all these things combined mean that we would call this a distributive shock. So no fluid leaving the body, the pump's working okay, but the fluid that is in the body isn't in the right places. It's too spread out and it's leaked into the tissues. And because we get this drop in blood pressure, that patient begins to feel sort of a bit cooler, and they have this weak, what we call a thready pulse when we palpate it. Now, thinking back to that microvascular circulation, we're going to think about the other things that are important to maintaining the perfusion of those tissues and the movement of nutrients and toxins and all the rest of it. Now, here's a diagram, not a diagram, rather a picture, an image of a blood vessel almost in cross-section. So you've got the red blood cells here in the centre, and these sort of flat little cells with the sort of dark purple nucleus that's stained here, these are our squamous endothelial cells, and then around it we've got the sort of tissue cells with their various nucleus, whatever sort of tissue that might be. And we're used to thinking of the capillaries being like a sort of tube with all the sort of red blood cells, white blood cells, and all the rest of it travelling in the blood. And then we've got this interstitial space and there's things moving in and out. And our endothelial cells, in this way of thinking, don't really do very much. They're just almost like bricks. They're kind of walls of the blood vessel. Well, there's a bit more going on with endothelial cells than this would suggest. And actually, if we look at so we're looking at a blood vessel in cross-section now. You can see a blood vessel in the middle, and here's the sort of plasma, if you like, and around it we've got their endothelial cells. And you can see within there they've got a nucleus, they've got mitochondria because they need energy to do things, and they've also got granules and fenestrations, and so they can do more stuff rather than just being a wall. And the functions of the endothelial cell are, yes, they are a wall. They act as a semi-permeable barrier, so they'll let some things through. They release a chemical called nitric oxide, which is a vasodilator. Now, if we think back to our diagram of the microcirculation, this helps control the flow of blood through the capillaries. And they also help maintain hemostasis, by which we mean they will trigger the coagulation cascade and switch on platelets when they're required, when there's tissue injury. And all of this is kept in check during health. So hopefully if we have an inflammation or an injury, this is triggered very locally and you don't see a widespread triggering of the coagulation cascade. So it's very tightly controlled in health. So yeah, this is just a recap of that microcirculation. Okay, now during an infective process, an inflammatory process, you get a load of white cells rushing to the area, and one of the first to arrive and one of the most lethal is your neutrophils. And the neutrophils are full of granules, and those granules contain things which kill microbes, which is great. But there's a lot of collateral damage, and the stuff within those granules will also damage endothelial cells, and that's fine if it happens very locally, but it's bad news if this is part of a dysregulated, uncontrolled response that we see in sepsis, because those endothelial cells don't work as well, and so they stop being such an effective barrier, and so we get fluid leaking into the tissues. They are unable to control the release of the nitric oxide, so they can't control how much of the blood is moving through the capillaries, and we lose that ability to vasoconstrict or vasodilate in the microcirculation. And they also lose their ability to help regulate the coagulation. So we get capillaries that get clogged up because we've got platelets being activated and thrombus being formed. Some of the neutrophils and the other cells that have these sort of toxic granules get trapped, which causes further damage. And because this is happening very widespread, the platelets get used up and the clotting factors get used up, which can lead to bleeding. So in this dysregulated response, we've got lots of issues here with our microcirculation. We have a drop in blood pressure, we lose control of our vasoconstriction and vasodilatation, and we get clots and all sorts of things blocking the flow of fluid through the tissues and blocking the flow of oxygen and nutrients getting to the tissues, which is what occurs in shock. Now, this can occur throughout the body in many different tissue types, and you'll recall we mentioned something called the SOFA score, which is helpful. We use a lot in critical care to describe and give weight to the various organ functions that can get worse, and it can sort of progress in severity towards a sort of very life-threatening multi-organ dysfunction syndrome. Now I'm going to discuss very briefly a couple of organs that can be very badly affected. The first of which is your lungs, and you can have this syndrome called acute respiratory distress syndrome, and this leads to hypoxia and your patient struggling to breathe essentially. So here we have a chest x-ray, a healthy chest x-ray, and the lung field is very dark. You can just about make out some patterning, which is very healthy. Everything's very clear to see. And in ARDS, we've got lots of inflammation. So this sort of more opaque, sort of shadowy areas here are just inflammation and fluid and all those terrible things that we see during sepsis. And it's perhaps no surprise that we get very hypoxic patients that are struggling to breathe. And there would be no surprise to you that these are all the sort of ECGs, and ET tubes and paraphernalia that you might see in a critically unwell patient on an intensive care unit. We also, because the clotting factors, there's inappropriate clotting happening, the clotting factors are being used up. This might explain the sort of rash that you may see in septic meningitis. So it's non-blanching, doesn't change colour when you put some pressure on it, like a piece of glass, for instance. Rash that is peculiar to sort of septic meningitis. And here some darker skin. It's important to be able to recognise it in a variety of skin tones. Now, because you can get all your clotting factors and your platelets being used up, you can head towards something called disseminated intravascular coagulation. So there's inappropriate clotting, but because everything's being used up, you're getting a lot of bleeding. You can see this intensive care patient here has got lots of bleeding and clotting, and this is a life-threatening condition known as DIC. So just to recap, septic shock involves impairment of tissue perfusion at the microvascular level. It doesn't necessarily mean your blood pressure will be low. The endothelial cells are vital to maintaining good perfusion, and a dysregulated response will injure them, leading to widespread organ dysfunction, and this may include ARDS and DIC. Thank you very much for listening.